Okay, so I'm going to talk about the glenoid and scapula fractures. I will start with a case. As you can see, this is a kind of an older patient, 62-year-old, has this injury. There's some anterior inferior or inferior glenoid fracture. These are some 3D images. There's a significant displacement of the half of the glenoid, 2/3 of the glenoid, the inferior glenoid. I don't think leaving this one would make the shoulder happy, so I ended up fixing this patient. He had a kind of a proximal humerus non-displaced fracture too that I fixed. This has been described a long time ago. Malgain, 1855, described similarly, as you will see that a bunch of description we have. So it has been known for a long time ago. I think scapula is not easy to break. To have your scapula broken, you need to have some severe injury because in case it's a lot of muscles and protected, you have a kind of backup chest wall in there. So it's very common that you're going to have 95% of the time you will have some rib, clavicle, or you're going to have some pneumothorax, one of the other. A lot of times ipsilateral extremity injuries, C-spine, sometimes the head injury too. So it's good to know that anybody who has a scapular fracture probably has an associated some significant injury. There's a bunch of classifications that I don't think they are super relevant to tell the truth, but everybody's tried to describe over the history either scapular body side or the glenoid side. Probably the more important ones are the glenoid side. I kind of put a kind of a circle around the common or more, there's a consensus about the indications and some kind of controversy in the what you see around the with the circle, the yellow circle. So the most common indication that there's a consensus when there's a glenoid fracture, again, not the body fracture, glenoid fracture that going to end up with some kind of glenohumeral instability. Or there's an articular step-off which is going to be 3-4 millimeters or more. Then there are other angles that are kind of mostly set it up by Peter Cole from Minnesota. That kind of, there's a bunch of literature, but it looks like it's mostly from the single center, so I will go over this too. The common deformities, like some of them will cause instability, although they are small kind of Bankart or large bony Bankart you want to call. Anterior inferior part of the glenoid, which is probably the most important part of the glenoid when you consider the instability. Or significant step-off, there's an articular fracture, there's a significant step-off or comminution. In a younger patient, probably the patient is not going to do well. The lower kind of part of the slide is a little more controversial. So floating shoulder or so-called floating shoulder, I would say, may or may not be an indication to do any surgery. Angulation in the body, how much you can accept, or glenopolar angle, which I'm going to show some of the examples too. Also the medialization or lateralization, whatever you want to call. We see this kind of X-rays or CT scans, although I want to operate on all of them. Unfortunately, it's hard to justify because most patients in the body fractures do well. I think you need to get a 3D CT with the 3D recons to be able to evaluate, especially the glenoid fracture with subtraction of the proximal humerus, because it's hard to assess how much of the glenoid is really involved. You need this kind of an en face view of the glenoid to be able to see. Articular step-off or gap. Obviously, there are two separate things, and when it comes down to the articular fracture in an upper extremity, which is a shallow joint, kind of shallow socket in the glenoid side, how much you can accept actually can vary. As you can see, I put the numbers over based on multiple kind of publications. It goes from 2 to 5 millimeters. 2 millimeters probably coming from how much you can improve. Again, step-off is not as tolerated as the gap. I think you can accept gap better than and tolerate the bad and not have bad outcomes, but the step-off is not very well tolerated. The way I try to decide regarding the gap or the step-off, if I think that in a young patient I can improve the joint congruity, then I will probably recommend I may operate in 2-3 millimeters. But I may accept like 3-4 millimeter gap in an older patient as far as the joint, humeral joint is not subluxed. When it comes to the instability, again, usually anterior inferior part of the glenoid, and the more it's involved, there's a higher risk that the patient may have some subluxation or microinstability that may cause arthritis in the long term. Again, this somehow we are extrapolating some data from the kind of instability literature from the sports medicine, but these are much bigger pieces. These are not like just the rim or the Bankart lesions only. They are bigger, at least the ones that in trauma word, the one we consider for fixation. Glenopolar angle, lateral border offset, and body angulations. These are kind of described numbers. I don't think these numbers needs to be very fixed. Again, probably I can sway you where to put that corner of the inferior corner of the glenopolar angle and make you more surgical or less surgical. I don't think there's very objective also which position of the shoulder you take it, these x-rays. I don't think they are easy to, and they are clear-cut, that they are not necessarily correlated very well. Again, we know that the angulation of the glenoid matters, but we don't know where the cutoff and how this patient is not going to do well. It's hard to know. Again, you're going to need to kind of select patients and depending on the patient's kind of choices too. This superior shoulder suspensory complex, or the floating shoulder, or between quotes, the floating shoulder, there are studies that have been shown that both ways, with surgery and without surgery, the patients may do well. I think you need to kind of see this patient, clinically examine them, and decide based on that, mostly younger patients, if there's a significant drooping of the shoulder, or they're not kind of mobilizing or getting more comfortable between a few weeks, you may consider to do surgery, because these are not intra-articular fractures. The common approaches are either posterior or anterior approaches. I will show you a few examples. This is a 62-year-old motor vehicle accident, had multiple injuries, referred 3 weeks later. Again, on the x-rays may not look that terrible, but when you go and get a CT scan, you can see that the significant part of the joint, half of the glenoid is involved and angulated, and there's a significant step off. These are the CT scans. Again, with the subtraction, you can see that how much of a deformity, how much of the glenoid is involved in this patient. This has been years ago, and I elected to fix this. As you can see here, both fixing the clavicle too, and at 4.5 months, she did a pretty good outcome after a posterior approach. This is another patient, is a 30-year hairstylist, so had to use the arm in this position most part of the day at work. Otherwise, it was an isolated injury, pretty comminuted fracture, as you can see on the CT scan, comminuted fracture. And this looks like, should you leave this alone? I think I will argue that in a young patient, I should not, because you can improve the quality of the reduction, and you can make this joint more anatomic or close to anatomic with surgery. We ended up doing surgery. This was a kind of the classic Jude incision with modified Jude, again, not reflecting the whole. This is like reflecting the deltoid first, but not reflecting the infraspinatus, using the infraspinatus teres minor interval. This was a kind of an older plate. I don't use the big plates anymore. I use just 2024, 27 plates, but it worked well for this patient. I think I improved the quality of the reduction of the joint quite a bit. And these patients, to tell the truth, they recover significantly better if you think that this kind of the big approach, raising the big flaps and all kind of things. Actually, you select the right patient, a young patient, and kind of more motivated to want to go back, they recover pretty well and pretty quickly, including the pain too. Then there are some limited posterior approaches. Again, there are select patients that if you go early on, and again, the indication in this patient, you can argue this was a Coast Guard who wanted to go back to work, and he didn't want any limitations, etc. There are some work things that he wanted to do. He kind of wanted the surgery. I think you can treat this one without surgery, but just doing 2 kind of incisions on the medial and lateral border, you can fix this fracture, but you have to do these limited approaches early on. I think after 1 to 2 weeks, it's very hard to do this surgery because there's going to be a lot of healing. Again, scapula starts healing pretty quickly. Even at 7 to 10 days, when you go over a scapula, it's going to be healed. So deltopectoral approach is going to be mostly for anterior glenoid fractures, anterior inferior glenoid fractures, because going posterior doesn't make any sense. This is a 56-year-old, fall off the scaffold, anterior inferior glenoid fracture, significant displacement. This may cause subluxation. Again, the joint is not that terrible, but with that gap, I elected to do surgery on him, that he doesn't end up with some kind of subluxation, anterior inferior subluxation of the joint that may cause arthritis. So fixed through an deltopectoral approach. The non-displaced proximal humerus GT fracture, I fixed it that I can start range of motion quicker, not to worry about it. Still, I had some displacement of the GT, but the glenoid stayed where it is, and it healed well. This was kind of a good outcome, too, at the end. Again, regarding the indications, glenoid fractures are the indications. Body fractures are controversial. If you think that the glenoid fracture is going to cause an instability or a significant step-off, I think this is a good indications to the surgery on the glenoid fractures. Glenoid body fractures, I think you can argue if they cause or extra-articular fractures when to operate. I think the cutoffs are not very well set up. Take-home messages. I think you need to analyze the fracture pattern and which approach, if you decide to do surgery, which approach is more better to get to the fracture and fix them. When you do posterior approaches, I think limited approaches are better, obviously, soft tissue friendly, but you got to get them sooner, and the fracture should be amenable to do that. These are usually extra articular fractures. You should do a modified Jude. I don't use the Jude approach. I rarely use the full Jude approach, which means that you got to reflect the whole infraspinatus off the scapula. It gives you a great view, but probably not a great thing to do because of the pedicle of the infraspinatus getting compromised. At least I think the infraspinatus gets some atrophy if you do that. And you got to be obviously paying attention to all the neurovascular structures. Thank you.